Well, hello everyone, and thank you for joining us for our HealthInfoNet's Behavioral Health Information Technology Reimbursement Initiative meeting. And we are privileged to be joined today by behavioral health home providers, all of the nurses, who have something to teach all of us about the power of leveraging real-time medical data to improve patient care and outcomes. And there's no one better to start that off than Jen Parent. Jen has returned to Maine from practicing in New Hampshire, where she had limited access to data. So in Maine, where she does provide medication management, comprehensive psychiatric evaluations at Tri-County, she has found it extremely helpful to have access to real-time medical data. And she's going to take us to some of her backstory and some of the work that she does so that you too can apply it in your practice. So Jen, why don't you take us behind the curtain and tell us how you do what you do?
Good afternoon, everybody. Like Gemma said, my name is Jennifer Parent, and I do comprehensive psych evals and medication management services for Tri-County Mental Health currently. So workflow before meeting with the client. So before I meet with clients, I like to know a little bit about them, which is always helpful in kind of helping them to actually get better. So we looked for facts on HIN. So we look for allergies, psychiatric medications, also other medications that they have, ED visits, if they're going to the ER or not, their PCP visits, and if they're getting their regular like risperidone constant injections, for example, we can see those because they pop up as primary care visit. Also the name of their primary care provider, or even the place where they go, such as CMMC or St. Mary's, which are the two local ones here, can be helpful. And to find the name of the PCP or other providers so that we can work together to kind of manage the patients. Next slide, please. Make sure to read the notes. So I believe that you can learn at least one thing from every note that you read. So we used to write a lot in our notes when we practiced, and now we really just don't have time to do really, really good thorough notes. But if you look at the kinds of things that we put in our notes, you can learn at least one thing from them. Sometimes it's that they are had a recent ER visit. Sometimes it's that they're getting a divorce. Sometimes it's that their social history, that they've picked up their use to a pack a day of cigarettes from a half a pack. There's all kinds of different nuances that you can learn when you read the notes. So every note that you read, you're going to learn at least one thing from. Next slide. Bringing curiosity to the notes. So it's not really about the data points that are there, but rather the story behind them. So a lot of times when you look at the medical notes, it doesn't look like there's much in them from a mental health perspective. But there's patterns there. There's a story of a person's life that unfolds when you read those notes. If you take one thing from each note, then you're going to kind of get a bigger story about what's happening for that patient overall, not just medically over time, but also mental health-wise and social developmentally. Next slide. Medical providers used to write more. So we used to I don't think there were as many primary care visits before, but there's lots of people in short time slots. PCPs get 15 minutes to see patients. I have a half hour as one of the lucky ones to do a follow-up appointment. And then our documentation time. We're really pushed to see more and more people quickly. And so we put less fluffiness, I guess, in our notes. The reports are scaled down, but there's probably information in the patterns. So again, looking at them from a different point of view instead of what they're telling you, but really the story behind what's there. Next slide. Searching the following data for clues. So meds, allergies, PCP, emergency contact, consults, labs, radiology. Those are the kinds of those are the tabs that I use the most for the most part, especially anything with head injuries, and also what kinds of providers they're seeing. So most people can't remember all of their allergies. They certainly can't remember all their meds. You know, I have people with med lists into the 23s and 24s or 48. I had one patient a couple weeks ago. If they went to the ER, they can't remember if they've gone to the ER since they last saw you. Consults are most helpful because usually they do get better background information. So if you see consults in HIN, those are like hitting the jackpot. Opting out versus opting in or opting all in, it's not necessarily what you think it is. Sometimes they misunderstood the person that was explaining what opting out meant. I've had that a couple of times. Opting all in, you know, usually people are like, oh, that means they don't have anything to hide. Well, it might mean that they're serious about their getting sober, about getting in their sobriety, and so it's one way to hold yourself accountable if you're ready to opt all in. So there's all different kinds of reasons. So if you see that somebody is opted out versus opting in, you can ask them about it, and sometimes you can get them to opt back in, and sometimes you're going to get a whole different viewpoint on a patient based on the decision they made to do either one of those two things. Social data, such as family composition, legal issues, peer interactions. So, you know, I had a guy who was constantly showing up at the ER because he was always in fights. One guy, his girlfriend kept, you know, physically assaulting him and eventually actually pushed him out of a third-story window. Legal issues, so if the police are bringing them in 4 or 5 times. Family composition, who's bringing them in, you know, who does the report say that they're living with? All of that information provides clues. Next slide. Using the data to identify the patterns. So ER visits, whether they're not using the ER, so a lot of patients that I have with schizophrenia or who are paranoid and delusional, they don't go to the ER because every time they go to the ER, usually it's really bad and they end up with an inpatient psych admission. So not going can tell us just as much about going too much. I had patients that use the ER for everything under the sun because they weren't educated as to how to use the medical system correctly sometimes, other times because they're getting their mental health needs from attention and somebody to pay attention and to listen to them through the ERs. Patterns from certain complaints, people that are going to the ER with pain all the time, especially like vague pain like abdominal pain or dental pain or things like that, sometimes can indicate some medication-seeking behaviors. Also, if they've, you know, keep going to the ER complaining of headaches and nothing is getting better, or, you know, just very vague kind of psychosomatic kind of symptoms that might indicate a personality disorder or using the ER in ways that they shouldn't. They should be really going to their PCP. Being on the same meds. Jim, I can't remember what that one was about.
Well, if they've been on the same meds for a long period of time, that might tell you something. Yeah.
Yeah, so we can track, you know, if they've been on that Paxil every time they went to the ER for the last 5 years, they've been on it, you know, that would indicate how long they've been on it versus if something was new and started, so you can kind of get a sense for how their meds have changed over time. Thank you, Gemma. And substance use disorders. When I first heard about HIN, that's kind of was like, oh, now I can you know, track that better. Or I have ways to do that because, you know, I can see their use patterns, but it's not just about, you know, catching them for medication-seeking behaviors or breaking their contracts or things. You can kind of follow the story of their life around them, which can be used in session to motivate them to make changes in their life and to help them to see the patterns that you're seeing. So opting out can indicate a drug issue or paranoia. I had somebody who opted out simply because they are paranoid about the government and the people and, you know, having access to their information and the internet and all of those kinds of things. And I wouldn't have been able to make the diagnosis of schizoaffective disorder for that person had we not had that conversation about why she opted out of HIN. Previous to that, she was just labeled as a drug addict, and nobody really kind of thought about her in any other way other than drug-seeking behaviors.
So I want to stop you just for a moment because this is just by looking at the patterns to uncover something so significant as this. I think you may be thinking you might tell this story a little later, but just in the sense of the importance of looking at patterns and how it can open up actually a whole new clinical diagnosis for you. Would we just take a moment right now, and if you could tell them this really, I think, fascinating story about how you uncovered, a psychoaffective disorder for this woman who had not been treated until you were able to do that.
So she, the patient that Jim is speaking about was receiving methadone maintenance at a local clinic for, I think, 7 years total. And she'd always been treated for substance abuse, and of course, she talked about having anxiety, and she talked about, difficulty sleeping and pain stuff because she has trigeminal neuralgia, and so she does have some legitimate pain issues. And so she kind of got labeled in this drug addict, and every time you would see an ER report, it would talk about medication-seeking behaviors, and she's talking about anxiety, but it's thought to be related to the drug-seeking, and it really kind of did this. And I noticed that she had opted out of HIN, and her PCP referred her to me because she was having this increased anxiety since she had gotten sober over the last, I think, 9 months. When she decided to stop her methadone treatment. And so she came to meet with me, and she started I said, well, it looks like you opted out of HIN. What was that about? And she really talked about, well, people can see my stuff, and they can, everybody's kind of connected. And then she started talking about there being cameras in the woods that are watching her, and this horrible traumatic PTSD history that kind of went along with all of that. The only reason, my cue for that was that she had opted out of HIN. I had even myself, knowing like all of this great stuff, had made the assumption that it was related to her substance use. But because I asked her, she was able to tell me that no, it wasn't. It was just because people are out to get her, and she doesn't know why, and it only happens when she's also not sleeping and all those kinds of things. And she met criteria for a major mental health diagnosis that was not only impairing her sobriety, but also significantly affecting the lives of herself and her children. She was pretty much in her room for most of the time because of what everybody thought was anxiety related to her drug use, when in reality it wasn't. So that's the story about that. Usage of the ED is emblematic of mental health status. A lot of times our patients go to the ER because they just don't know where else to go and where else to get help. And so even though it's not specifically a mental health complaint, you can kind of see that underneath as you follow it through time. Sometimes I don't find anything, and that tells me something because they're not using the ER, or they don't have any PCP visits, or they don't even have a PCP listed, and there's usually reasons why they're not engaging in any kind of medical care at all. And a lack of pattern shows a pattern in and of itself. Next slide. What we can infer from the patterns. So I use HIN to kind of pull all of the pieces into a puzzle, along with some other things like the prescription monitoring program and our records here at Tri-County and PCP records that we get separately. The psychosocial evaluation is a snapshot. Our patients are not just a snapshot moment of what's happening when they're in our office, and we kind of forgot that in medical and in mental health world, that it's not just what's in front of you. There's a story behind it. And if you gather enough pieces, then you can put the puzzle together to determine where it is that they're stuck. The premise of our BHH here at Tri-County is that if we can figure out where we're stuck, where that person is and why they're not moving forward, and we can work on that actual issue that's making them not engage in their treatment or not get better or not sustain their health, that we can improve overall health and wellness. Next slide. Our roles have changed. So we're looking at changing how we practice as mental health providers. So before, when a patient would come to see me, a new patient for medication management services, they would be put in my schedule. I would look in the chart to see what information I could find, and then I would meet with them for about an hour, and I would say, okay, this is your diagnosis, and these are the meds for it. The new role that Tri-County has created was I get 2 hours to meet with the patient, and then I have an additional 2 hours to gather information and to come up with a master plan as to where they're stuck and what's going on for them, in addition to the traditional med management role. So we And the reason that we looked to change that was because we realized that people weren't actually getting better by any standards. And in order for us to continue to practice, we felt like we needed to prove that what we were doing for interventions were actually increasing the quality outcomes for people. So there are all kinds of things that you can measure. The latest is, ER visits and overutilization of the ER or hospital readmission rates and all of those kinds of things. And we're kind of preparing to be able to prove that our interventions that we're doing in our office are working. In order to improve somebody's their medical health, you have to figure out why they're not improving it. And those are very often whether they're a traditional, very sick, chronic mentally ill person or just normal average Joe Smith. There are usually mental health reasons behind that or something that's stuck in the way of them being able to do that. So that's kind of why we're looking to change up how we do things here. Next slide. Looking at the bigger picture, there's a difference between PTSD and bipolar disorder. We, as a society, are geared towards finding fixes for everything. Traditionally in the medical role, you go into your doctor's office or to the ER and you say, this is what's going on for me, and there's a pill for that, or there's a diagnosis for that, or there's a treatment for that. And the mental health world does not work like that. And I really feel as a practitioner and as a practicing provider that we have gotten out of control. It is not statistically possible to have this many people with bipolar disorder according to the relative prevalence rates. PTSD looks a lot like bipolar, and if you don't get all of the information on a person, or as much as you possibly can, or they're using substances at the same time you're trying to diagnose, and you don't even take the time to look into that, or you don't really get a good feel for what it was like to live in their house as childhood, you are going to misdiagnose with bipolar disorder. And I really feel like there is an abundance of that. And for patients, when you get told that you have bipolar disorder, it really takes the ownership away from you, that there's nothing you can do. You have this thing, and there's meds for that, and that's going to fix it. And you'll hear people say, well, my bipolar kicked in, and I freaked out on my kid. And it just really doesn't look like that. So getting those backstories, getting that bigger picture, that information on your patients is really going to help you get a better diagnostic picture of where you need to go going forward for them to help them. Next slide. Using HIN to track increased health through new skills learned. So using HIN when they come to meet with me for the comprehensive evals that we do, patients will come in and we'll kind of try to figure out where they're stuck, what they need, where they need to do. One patient, or a couple of the patients actually, was able to decrease her emergency room utilization. And so she was following the plan of her doctor. So she has legitimate extremely bad asthma and extremely bad diabetes, and she was told that you're going to do this, this, and this, and then you go to the ER, right? And so basically she was following the plan that was set forth by her asthma specialist and her diabetes specialist and her PCP. They gave her certain algorithms that she was supposed to do, and the bottom line is that the algorithms weren't working, and she did follow them, but her ER utilization was just ridiculous. It was like 30 in a month over the last 4 or 5 years. And so she came to meet with me, and what we discovered was that, one, they were telling her to go to the ER. So she would call her providers, and they would say, did you do this, this, and this? And she'd say yes, and they'd say, okay, well, then go to the ER. I mean, we're talking about her calling with blood sugars in the 300s and 400s and asthma attacks and not being able to breathe. So they were correct in sending her to the ER. But what they didn't uncover was that the reason that she was not getting better or not showing an improvement and continuing to use the ED for a rescue was that she was, sleeping upright in her chair at her kitchen table. So she wasn't getting good rest, and she was, not eating the way that she was supposed to because she didn't have a good understanding of what she was supposed to eat and of how much. And there were all of these different little things that would have improved her blood sugars and improved her asthma. Oh, and she was walking for 4 or 5 miles a day because she didn't have any transportation, so, an asthma attack. So she just had all of these little things that if we were to work on those things a little bit at a time, that we would hopefully see gradual improvement in her blood sugars control and in her asthma, and then that would decrease her having to go to the ER. So over time, she was able to do that. And we're not there yet, and we have a long ways to go in terms of managing those chronic illnesses. But she was able to decrease her use, and I can't remember the exact statistics, and she's still going quite a bit. But even that small amount, if you take it from 30 times a month, and now she's only going 25 times a month, that's an improvement. And so focusing on good, you did a great job. So when she comes in, we check HIN, we see how much progress she's made. If she slid backwards, then we talk about why, and then we fix that, and then we kind of move forward. So that's one example of how that whole process works. Without the HIN, I wouldn't have seen her pattern to decrease the dependency. So if I can't see it, then I have to, call the ERs and get all of those reports and then have time to look at all of those reports as opposed to the plain facts that are in front of me. I can just simply count the dates that they have on HIN now, which is much easier. So we really developed a new treatment plan for her to reflect her progress, and it also reinforces it that she can see that she's actually doing better, as opposed to constantly hearing from her providers, don't go to the ER, don't go to the ER, don't go to the ER, and then at the same time they're telling her to go. One of the things that I noticed is that we kind of make them dependent on us. Without HIN, I wouldn't have seen that it was her pattern to decrease the dependency. So our patients, our clients that have seen us for years are really dependent on us to do things for them. And we stopped assessing whether they were ready and able to start taking over some of those responsibilities to eventually not need us. And that's one of the big drives within our BHH now, is to be able to make people more independent, to teach them the skills that they didn't learn from their families because of whatever reason, whether it was abuse or neglect or significant trauma or any of that stuff. A lot of people that we see did not get the skills they need in order to be independent, and so we're trying to teach them. Next slide. Examples. So HIN has proved extremely helpful in finding people. So traditionally, that's usually what the ACT team does when you have the 3 contacts a week, and they go get people if they don't show up. They go find them. So HIN has made it a little bit easier to do that. So I had one patient who had received services all up and down the coast, all the way down to Florida, and we got those records. But what HIN did was I was able to map where he was in the state of Maine during different time periods based on which ERs he was hitting up. So this patient has a schizophrenia, a psychotic diagnosis, and kept utilizing ERs basically when he would run out of money from his check because he was own payee. And so we were able to track it which parts in the state, whether it was in northern Maine or around the Bangor area or in southern Maine or in Lewiston, we were able to track it which points in the last couple of years he was located. And even from the lack of data when he was out of state, because he always uses the ER. So if there was a gap for 6 months in 2016, he was not in Maine. He was in another state. So we were able to kind of put that all together, to put the puzzle together. We were then able to stop his, or to file for guardianship through his Social Security so that he wouldn't have access to stop traveling and doing this consistently and overutilizing resources and avoiding treatment, to be able to engage him in services. He was not happy, but probably doing better because of that. Overuse of emergency rooms in different years. So emergency means emergency, so that means people are in crisis. So if you're looking at HIN and you're seeing that in 2012 they went to the ER like 18 times, and in 2013 they didn't go at all, and in 2015, they went like 40 times, I guarantee that something was happening for them whether it was medical, psych, or socially, that was making them go to the ER all the time. And so if you look at just the number of times they go in different years, you can see a pattern or a lack of pattern from that. Going to the emergency room to resell drugs. When you run out of drugs and you owe people money, you have to get them somehow, so the ER is a great way to do that. And so I had a patient that was going to the ER to obtain things to divert, controlled substances to divert. And it was very clearly evident in the medical record. Multiple ED visits from drug-related assaults. So this one guy I saw kept getting beat up, and he kept ending up in the ER. But he never really would say kind of what was going on. He didn't really point any fingers. He didn't say anything. But he just kept coming into the ER with these injuries. And the doctors would say things like suspicion of that he got into a fight, or it seems like that, or he said this, which indicated that. And when I said, hey, dude, what's up with all of the ER visits? You keep getting beat up. Who's beating you up? He said, well, I owe people money, and then I don't have it, and I run out of drugs, or I was selling and I didn't have the money, and so they kind of beat me up, and then I got to go get stitched up again. And so we were really able to kind of piece that together for him, and then to come up with a plan for what to do next. Next slide. Access to HIN changes the treatment strategy. So before HIN, I based the treatment interventions, and for me as a med provider for mental health, that my primary treatment intervention has always been medications. And I based what meds they needed to be on based on what they told me. And when you think about the fact that a person's perception changes drastically over time, that is just ridiculous, because they are going to tell you whatever symptoms or whatever thing is happening for them right now in this moment. And most of the time it's not even, or sometimes it's not even consistent with what's been going on for them in the last week or the last month, but more what's going on for them that day when they come in. And to base medical decisions based on that without collateral information, I've come to feel is not cool. So now it's really about kind of like their thinking pattern and the information that I can gather that either supports or disputes what they're telling me in my office. So the more people that you talk to around your patient, and this is the reason why they give me 2 hours to gather data and 2 hours to meet with the patient, is to allow time for that to happen. The more information you can gather, the more thorough of a picture you can get for what's happening for a patient. And to make treatment decisions based on more information, I don't think could go wrong, as opposed to making decisions based on less information. Next slide. I think you're the only person who's read my stuff. I hear that a lot. I think in general, patients feel, both in medical and mental health, like we're not paying attention as providers. People, when I read even like progress notes in our own record at Tri-County and in HIN, you'll see people come in and they talk about the same thing over and over again. So whether that's pain or whether that's anxiety or whether it's depression or whether it's, psychosis from inpatient admissions, patients don't really feel heard. And if you take the time to read the notes or to look for data to support or dispute what they're saying, or to even get a sense for what's happening for them, the bottom line is if a patient says they're anxious, their perception is that they're anxious. So taking the time to read that stuff and saying, geez, I noticed that you have, that you keep going to the ER, and every time you go you say that you're anxious. What's that about? What's it like to be you? What is that? What is that? Nobody asks patients that anymore. And so by reading all of their stuff, or a lot of their stuff, and I don't claim to read it all because there's no possible way. I mean, one of the women that came to see me had 394 ER visits. I do not have time to read all those. But you can read enough to get a gist for what's happening, and you can bring that into your session with them, and developing that connection with a client or with a patient is going to improve their healthcare outcomes and overall health and wellness. Next slide. The BHHs were set up to increase quality outcomes. Currently, we get paid for what we do based on time or based on the amount of problems or diagnoses that are on their chart. And Tri-County feels that there's going to be a shift so that we're going to get paid based on whether we make people look better or not. Now, whether that happens or not is irrelevant, but at Tri-County, we really feel that we need to prove that what we do is actually working and that people are getting better by measuring how many times they go to the ER, by measuring how many meds they're on, how much dosage is, if they're going to therapy, if the things that we are doing are reflecting that they're getting better. My position at Tri-County, doing the comprehensive psych evals and medication management services with more collateral information, was created to do a more thorough job and to increase the quality of a person's life. So figuring out where they're stuck and being able to utilize that information to activate the patient, to motivate them, to take the time to gather their adverse child event scales or ACEs to determine that they've had 9 out of 11 adverse child events, which historically is trauma issues. To take the time to do all of that stuff, to recognize what that person has gone through in their life up until that point, and to utilize all of that information to be able to make real treatment plans to improve the quality of life. Next slide. We have a vision, and HealthInfoNet helps us to get there. We want to see improved healthcare outcomes, both mental health-wise and physical-wise, medically for our patients. And we need HealthInfoNet and sources like it to be able to help us to get there. We can no longer just rely on what the patient tells us in our office as truth and factual. It is, and it's what's going on for them right now in that moment, but you have to take into consideration everything else around them to make good diagnostic and treatment considerations.
Well, thank you so much, Jen. Really appreciate everything you've shared with us today regarding how you use HealthInfoNet and how all of the listeners can also use HealthInfoNet using real-time medical data to increase quality outcomes. But not only that, you've really shown all of us how it also increases quality of life for those concerned. So really appreciate the time. Thank you so much for joining us today.
Thank you so much for having me, Gemma.
So we at HealthInfoNet are so fortunate to have a powerhouse of clinicians who use HealthInfoNet on a daily basis to provide quality care and best outcomes for their clients. And so we're going to be starting today with Elizabeth Mann, who's going to share with us some ways that she uses HealthInfoNet. Now, Liz is the nurse care practitioner at the Opportunity Alliance, and she's been a heavy user of HealthInfoNet for a long time now, so she knows a lot of how you might be able to use HealthInfoNet in your practice as well as a behavioral health home. So Liz, there are 3 questions that I'm asking all of our fantastic nurses on our clinical panel, and the first one is, what are your top 3 favorite uses for HealthInfoNet?
Okay, so number 1 would definitely be the notifications that myself and our entire team receive when someone is seen in the emergency room or have been admitted or discharged to the hospital. So getting those notifications in real time has really made an impact on our ability to get in there early and support those transitions of care and provide any coordination or follow-up that the client may be recommended to do. So that has really been really essential, especially in targeting our folks who have, are frequently going to the emergency room in particular. The second top use for me personally has been in accessing physical diagnoses, medications, and also any substance use history. Here in our program, we really have been trying to get a better sense of who our clients are really, and identifying any major contributors to morbidity and mortality that they may be struggling with. And so in particular, looking for the presence of chronic disease, things like diabetes, cardiovascular disease, COPD, and then other risk factors for chronic disease, including tobacco and being overweight or obese. And so that's information that is quite often readily available right there in HealthInfoNet, and so that's been really helpful to me. Also, there's been the Main Care Data-Focused Learning Collaborative initiative around atypical antipsychotic use and ensuring our clients are having their A1Cs done regularly. And so HealthInfoNet has been a great source of information for us on that point as well. And so, a lot of the times our clients undergo a pretty comprehensive intake, but sometimes that information isn't quite accurate or it might be missing. And so HealthInfoNet really does help fill in the blanks. Additionally, a lot of this information could be accessed through the primary care provider, but often that can take a lot of time and effort. And a lot of our clients, or some of our clients I should say, might not even have a primary care provider upon entry into our program. And so HealthInfoNet really has been the main source of that really important information for us. And lastly, it's really great to find out who else is involved in the client's care, so other providers they might be seeing, whether it's primary care or specialists, and also their utilization of outpatient health care, so radiology, and so that's been really helpful for us. We're able to see when they were last connected with that person. We're also able to see kind of how engaged they are in their care, if they are getting those recommended radiology tests or making those follow-up appointments. And so I would say those are the three top uses for me for HealthInfoNet right now.
And would you say you go in every day?
Absolutely, multiple times a day.
And so when you, as a workflow, you go in first thing in the morning, you say multiple times, is it pretty set for you, or is it something that happens while you're in your patient workflow?
Certainly I try to respond to any of those any of the notifications that I receive, but it's part of kind of several different workflows I have, as I outlined around the chronic diseases and the antipsychotics. And so I might not go into everyone's chart regularly, but certainly on a daily basis I'm going in to extract some information for some clients. So it is a part of my daily workflow, but in different ways every day, if that makes sense.
Yes, it does, probably, because your day is never the same, right? It's different every
Correct.
day you go in because
Right.
of the nature of you're working with individuals.
Absolutely.
So talking about working with individuals, this is probably a hard one for you to pull out because you use it so often for so many people so effectively. But would you share one story with us about a time when HealthInfoNet really made a big difference for one of your clients?
Sure, I'd be happy to. And this is an example that it was more of a behind-the-scenes kind of thing where I feel like having access to HealthInfoNet really made a big difference for us, meaning myself and the client's care coordinator, which obviously then would have made a big difference for the client whether or not she realized it. But just actually, this is a recent example of a woman who is 50 years old. It has a history of paranoid schizophrenia and anxiety. She has a significant trauma history and also a significant history of institutionalization. And from what I can gather, it was, kind of put forth to this individual that she would never really, wouldn't thrive or even survive outside of an institution. But she has certainly exceeded all of those expectations, those low expectations, and she has been very active in the community and living independently for quite some time. So this is a woman who just recently had her first mammogram in several years, and it ended up coming up abnormal. And so that, of course, set off this cascade of events where she had multiple appointments with new providers. She underwent additional testing, including breast ultrasound. She had a skin biopsy. She had a core breast biopsy. She actually had a whole body scan to look for any cancer that may have spread. And so unfortunately, her diagnosis did come back as a breast cancer that had spread to her bones. And so HIN has been really instrumental in allowing myself and the care coordinator to access the results of all of those tests pretty much as soon as they were available. And what that translated to for us was less time spent on trying to, get a hold of those records kind of the old-fashioned way, calling around and relying on faxes and all of that. And it provided us more time to focus on the much more important tasks, like kind of between myself and the care coordinator, reviewing those results together, getting a good understanding of what those results meant, and so essentially preparing us to be able to provide the best support to the client that we could offer, certainly helping to coordinate care around all of those new and sort of urgent appointments that she had been set up for, and also helping the client prepare for those multiple appointments and establishing new relationships with providers who were strangers to her at the outset at a very difficult, obviously a very difficult time in her life. So HIN was really incredibly helpful in giving us all of the information that we would need really in a timely manner to be able to help support the client through this time.
Well, Liz, it's a beautiful example of how important it is for providers to give a warm handoff to a new provider when you have someone who has, high mental health issues, such as this particular woman. It's a beautiful story. How's she doing now?
Thank you. She's very early on in her treatment, obviously, but she has. I feel like her perspective has certainly improved, and it seems like she's handling it, as well as you would expect anyone to. I think so. Doing well, as well as she could, I suppose.
And you certainly set the platform for it to be at the best possible quality as you could possibly pull off. So
yeah.
It's a great use. We think of technology as not being personable, but what a great example of that is so not true.
Yeah, absolutely.
So now a lot of folks are listening because they are new to the behavioral health home world, and you come from a lot more experience than people who are starting out. So what recommendation would you make to an organization that is new to the behavioral health home so that they could be as successful as you are?
Sure. So I think the main recommendation from me is to not limit access to HealthInfoNet just to the nurse care managers or the clinical supervisors in the program. And obviously I can only speak to kind of the caliber of our care coordinators here, but they have been heavily involved in care coordination and integrated care far before the BHH came along, and so they are very knowledgeable, very savvy. They have a lot of experience that they bring to their positions, and so they are and have been perfectly capable of using a lot of the information in HealthInfoNet in their work that they do with their clients, and doing so without working outside the scope of their practice or the scope of their roles, and in a way that they feel comfortable, doing. And so I have heard here and there about programs who really restrict access to a few people in a program, and while that may work for some folks, I don't think that we would nearly have had the success with HealthInfoNet, nor would we have been able to really see how much it could offer us if we had only restricted it to just a few people within our program. So that would be my main shout out, and encourage folks to really consider that within their own programs.
And so can you give us a little bit of an idea of what that would look like for a care manager to go in and use it? What have you seen has made a difference with it when a care manager has access?
Sure. So a lot of times the medications are a big one. A separate kind of expectation workflow in our program is that they do a medication reconciliation regularly, ideally every 90 days, and then at points of transition. And so having access to HealthInfoNet and those medications that are really quite current has been incredibly helpful. As I had mentioned before too, being able to identify people who are involved in the client's care has been really helpful for them. Also, they respond to their own notifications of clients on their caseload who have been hospitalized or been in the emergency room. And so they're able to kind of access that information and then follow up up with the client. And that's something that I, as a nurse care manager, do as well, could do. But when you're talking about me being the sole nurse care manager for a program of 450 folks versus a care coordinator who has, a much more limited, 30 or under caseload of folks that they've already established, for the most part, really strong relationships with. I think that is where they're able to make more progress, let's say, on identifying reasons for accessing the emergency room than I might be able to as a stranger to these folks. So I think having the care coordinators having access to HealthInfoNet is just so really now vital to the work that we do.
So it allows really a more timely intervention too.
Absolutely.
Yeah,
absolutely.
That can make a difference. Time when somebody's in some acuity can make a huge difference.
That's right.
Yeah. Well, thank you so much, Liz. Really appreciate your insights and your the great work and support you do on behalf of your clients and leveraging HealthInfoNet in really the way that it was put out there for everyone to use, which is to increase the quality of care for all of us here in the state of Maine. Thank you so much, Liz. Really appreciate it.
You're very welcome.
Now we're going to hear from Doris Skarka. Doris is the nurse care manager for United Cerebral Palsy. And Doris, you go into HealthInfoNet a lot. I would say on average you go in at least, about 190 times a month. So you have a lot to share with us. And I'm going to ask you that first question we're asking everyone. What are your top 3 favorite uses for HealthInfoNet?
Thanks, Gemma. I really do use HealthInfoNet a lot. I absolutely don't know how we existed before HealthInfoNet. So I just want to say that it's one of the greatest tools that I use in my practice here at the BHH. First of all, I guess one of the top 3 favorite uses for me regarding HIN is the setting notification alerts piece. I use that for my high utilizer clients or ones with acute medical or mental health needs. And what that does is it gives me the most current information, and it gives it to me in the most timely and efficient manner. I can track people who I know have frequent ED visits with this. I can track medical clients who have needs that require having testing done and then reevaluating and implementing a different plan of care. And with the alerts notify me, and I do not have to spend my time going in, clicking in each client and trying to get that information. It's readily available for me when it actually happens. So setting notification alerts for me is one of my favorite uses. The second favorite use that I have, I do a lot of tracking and follow-up for quality monitors, and that includes ED visits. We look at well child checks, different types of blood work monitoring, just as an example, A1C monitoring for antipsychotic meds, lipid profiles, those kinds of things. And all that data is easily accessible for me in HIN, especially because it's just, it's right there. All you have to do is click on the laboratory results or whatever. But the other piece that's, I think, is very important on the HIN screen is the patient summary, because I utilize the patient summary as kind of like a snapshot of the information around the clients who they've interacted with within specific periods of time. And I'm also able to kind of use that as a screening out tool if I'm using it, if I'm looking for someone for a well child check, for example, to make sure that their yearly exam was done. Especially some of the children I have, they have a lot of outpatient visits. I can go to the patient summary and I can identify by just hovering over the code in the patient summary and aligning it with a specific date. So it saves me time trying to flip through a lot of the outpatient data to find that information. And the other piece that is very helpful for me with those quality monitors are the drug fills, the 120-day drug refills. It lets me know what the clients are on for medication and if there have been any changes and what has been filled. Not necessarily what they've taken, but what has been filled. So I find that very helpful also. And then I guess my third favorite use for HIN is what I call real-time teamwork. And what I mean by that is if a health home coordinator or myself have an issue, we communicate as soon as possible utilizing, let's say, email or phone instead of waiting for our team meeting. And what we do is we review the client in HIN, and we decide if we need to have targeted follow-up for this client. So it really gives us timely information. We can do it quickly, and then we can decide if this client really needs some follow-up, and then what type of follow-up. So those it really, really helps us in our teamwork working together. So I guess those are my really top three favorite uses for HIN.
Sounds really good. I can see also that you use your care managers very closely. Not all of our organizations are set up that way, but for the ones that are, did you have anything you wanted to add about what makes that a successful interaction when using HealthInfoNet?
I think what makes it a success is that both of us are tuned in the client needs, and the case manager, or the health home coordinator I should say in this case, has all of the information regarding the client, their socioeconomic situation, what's happening in the home, etc., bringing that expertise. May not totally understand all of the medical piece that's in the HealthInfoNet, and then I bring the medical expertise from what's in HealthInfoNet, and it really makes a nice blend at that time so that we can look at what's happening with the client and really decide what we need in resources to help our clients at that time. So I think that's what helps.
Thank you. So our next question, if you would share one story with us when HealthInfoNet and access to the portal made a big difference for a client.
Well, one story I'd like to share with you where HIN made a difference for a client of ours. We had a teenager with a major depressive disorder. And it was recurrent, it was severe, without psychotic features. And in utilizing the information or data from HIN, we found out that the client had 10 ED visits within an 11-month period of time, 6 mental health inpatient stays, and 1 partial mental health program stay. So we decided we needed to really take a deeper look at this. So the health home coordinator and myself sat down and we developed a timeline from the ED visit notes and of all the ED visits. And we analyzed them, looking at how many occurrences, the time of day, what part of the week. We looked at what precipitated or caused each visit. And then we looked for pattern development. Did the ED visits happen every 4 weeks, every 6 weeks? Was there a pattern with the ED visits? Then we looked for a repeating cause or a trigger or multiple issues. What was actually identified as the cause for each of these admissions? So we looked at those variables. We also looked in HealthInfoNet for medication information, and we looked particularly on this client. When we noticed that medications were not filled. So that was really a red flag for us. if they're not filled, they're really not readily available to take. So that was a definite red flag for us when we were looking at this case. So utilizing all these resources that I talked about from HIN really enabled us to identify different behaviors or concerns for the client and the family. And it did it in a timely manner. And the red flag of not getting the medication filled was very important to discuss with the client and family. And our health home coordinator had such a great rapport, which they all do really. They really develop, they're really the key to a successful behavioral health home, because they really developed the trust with the families and was able to explore that very with the family as far as not having the medication filled, and there were some really good insights into why it wasn't filled, and discussions occurred regarding that. So with all the accurate information that we received from HIN, it made it possible to meet our clients' needs. And what we were able to do was put appropriate supports and resources in for this client. We had outpatient therapy, definitely med management. We did home community therapy. And we utilized our peer support specialist also for this client. And we were able to do that a lot quicker, I think, based on being able to analyze everything so quickly with all the information being there right in HIN. It really made us be able to put all these supports in a really timely manner. And we were very encouraged with the results. Our client, after we put all the resources in place, did not have any ED visits for at least 8 months after everything was in place. So for us, that's definitely a case where HIN made a big difference. It made us feel good about being able to identify different needs for this client, and it made a difference in the client in not having to access ED visits all the time also. So we were very, very pleased with how this case turned out. Now, as we all know, it's on a day-to-day basis because different stimuli come into the picture with these kind of cases too, or family issues, change in medications, those kinds of things that may present other issues for us to take a look at. But again, we will use HIN as a resource, which has been very helpful for us in the past. So I wanted to share that with you.
It's a great story. I think on a lot of levels, not only were you providing the support in real time, but you're also recognizing that with this particular very a population that has so many challenges, that things can change very quickly in a heartbeat. And to return, if she were to return to the ED, that does not indicate any kind of failure on the part of, and saying this on behalf of all behavioral health organizations listening to your story, because just by the reduction of that is really significant, and not just in terms of cost to the payer, but also wear and tear on the individual and their families going to the ER. I know we've had this conversation, Doris, before, how going to the ER is not, that's a very traumatic event to do that. So to provide these other supports is so big what you all did. Great story, thank you. And I have another question for you. We do have a lot of behavioral health homes that are coming into HealthInfoNet for the first time. They're starting to use the portal, and you have so much experience going in. What recommendation would you make to new behavioral health homes who are just getting started with this work?
One recommendation that I would make is remember that you need both real-time data from HIN to be proactive. It's very, very important. And you need teamwork between the health home coordinator, nurse care manager, anyone else on the team with real-time communication. That's what really makes a successful BHH. If we if any one of the teams sees an issue or has a question, we talk as soon as possible so we can support our clients. Utilizing HIN, rolling it out, to be honest, is, you're very helpful in helping us roll HIN out. So it went smoothly pretty much. There are always some computer issues, those kinds of things. The program itself, to tell you the truth, is really very easy to use. So once people feel comfortable going in and accessing the data, the real key to being successful, as far as I'm concerned, particularly in our BHH, is the communication factor between everyone on the team, being able to do that, and all of us utilizing HIN. The health home coordinators definitely go in, and they may not understand everything that is in there, and then what happens is I get an email, we both sit down and review that patient, and we talk about what the data is in HIN regarding that patient and what it possibly could mean if the patient needs some follow-up. So I think from my perspective, I would recommend that all of us in the BHH utilize HIN, and then the most important thing too is the communication piece from my perspective. So hopefully that's helpful.
It is helpful, Doris. You've given us some good insights into actually why you go in 190 times a month. No wonder you see such value in it, because you bring the curiosity to the data and the desire to take care of your clients and to work as a team. And you do see part of your role as educator to not only to the clients but to your staff, and so that you can work together as colleagues on a team. So wonderful, wonderful stories today, and thank you so much for sharing not only your experiences but giving us actionable examples that the people who are listening can follow themselves, and that can benefit all of our clinical portal users. So thank you very much. And now we're going to be hearing from Brenda Mailman. Now, Brenda is the Nurse Care Manager at Community Health and Counseling Services, and it's just wonderful to have Brenda on with us today, because actually Brenda is one of the first behavioral health providers to use HealthInfoNet, and so she brings a lot of experience, and I think as we ask these questions, it might have been a little more difficult for Brenda to answer them because she's been using HealthInfoNet for such a long time. But with that, I'm going to ask you, Brenda, this hard question for you, because you have so many examples. What are your top 3 favorite uses for HealthInfoNet?
This one is very hard for me. I use so many of the items every day, and every day I have a new favorite. And it's but the ones that I like to use a lot is labs for patient education. I like to show my patients, like for instance a diabetic patient showing their A1C or where their glucose has been, to be able to bring up the labs that they can't remember what the answer was from their PCP, and just show them whether they're making progress or not making progress and what we can do differently. So many of them come in and they say, oh, my PCP did an A1C, but I don't know what it is. And I try to explain to them the importance of numbers, and by doing that, we just go back into HealthInfoNet. We see the numbers, I explain the numbers, and it just makes a huge difference for them, because I've had some patients that just say, oh, that's what that means. When they go to the PCP, they don't feel that they can ask those questions. Another one of the things that I like is the prescription part. I can tell if they've had them filled. So if they've been ordered a certain medication and everybody's wondering if they're getting it, I can see if they've had it filled at least. And then I'm able to call them and say, I saw you had this filled, but do you know how to take it? Have you been taking it? Do you have any questions about it? And also it lets me know what pharmacy they're using, so that I'm able to chase that down also. Another one of the things that I love to use is office visits. So many people go into a doctor's office and they just don't have a clue what the doctor is saying, or they misinterpret, or they just can't remember because it's a busy time when they're in there. And I'm able to go back to the office notes and see what was said and what they discussed and what their diagnoses are and if their medications have changed, and to be able to go over that whole visit with them and ask them if they have any questions, and to be able to explain what the doctors, were saying to them. So that has come in really handy. It also comes in handy if, my case managers come to me and say, did they make it to that visit? I'm able to go in and see if they made it to that visit, and that's really helpful.
I'm really so struck by a theme that's coming out as you're speaking, which is how you're able to give some sense of control back to your clients who are doing something very vulnerable to them, going to a strange, doctor, or it might be their regular doctor, but they're not comfortable like they are with you to ask questions. And you give them numbers, you give them actionable data, you give them some control back. Do you find a sense of relief from them when you're talking with them? And
yes, I do, because I've had, people go into their primary care office or even a specialist office. The specialist says something and they only hear one word. This is going to kill you, or something like that. I had a patient that went into a cardiologist's office, and with the issue that he had, if he left it untreated, it was going to kill him. But all he heard was, this is a death sentence, and didn't understand what he could do to prevent that. So by going back in and looking at that, you empower them to take control of their health again. They're able to know what they need to know.
It's kind of what goes on behind the data,
Mhm.
Yeah.
It is.
So you just shared one story about making a big difference for a client. Why don't you go ahead and give us another one? I know you have a lot.
Oh, I do have a lot. It's amazing. One client that comes to my mind, and it was just recently. Their end of their story was changed due to ER alerts, which is awesome. I was alerted in the morning that this client that we have worked closely with in our BHH program was in the ER for suicidal ideations and for a psychiatric eval. She's there by herself. She was very upset, very vulnerable at that time. And because of this notification, I was able to get our peer support and send her to the ER to support her while she was there and going through the whole process. And she was ultimately admitted to the psychiatric facility, but the peer was able to be there with her, follow through with some follow-up visits, and make phone calls, all because of our knowledge that she was in the ER. I mean, it was amazing. And in a different time, we wouldn't have known anything until she returned home if there wasn't for a notification system, because you don't hear when they go in for psych evals or, go into Acadia or another psychiatric facility.
Yeah, and what you don't hear also is is how perhaps her treatment or her response to treatment was better because she had that relationship with your peer support that you were able to put in place.
Yeah.
At a key time.
And it's wonderful for her to have that supportive person while she's going through that traumatic period.
You talked about the peer support, and because there are going to be people listening to this who are new to behavioral health homes and using peer support, you have found it to be extremely helpful. Can you talk a little bit about that for people who are listening to this today?
Our peer support is awesome. We have some of the best peers here. Our particular peer support is a person who has previously used services and now is in recovery, and she does a wonderful job. She knows where the clients have been. She knows where they're coming from. She knows what they're talking about. She goes and she supports people, whether it be at a doctor's appointment, at an emergency department, or just going into their homes to give them a better support system to make it outside of their home for some people.
It's very powerful, the stories you've told and the one you told today. As I mentioned, we have people listening in who are new to behavioral health homes and wanting to really use HealthInfoNet in a way that maximizes the tool and also their work. So you've been doing this for a long time. You are a master teacher, Brenda. What would you recommend to new behavioral health homes, to nurse care managers, to anyone listening in who's looking for some tips and strategies? Communication
with your case managers and with HIN. HIN fills in so many of the gaps for me. Don't be afraid to use it. Don't be afraid to get in and check things out, thinking, oh, I shouldn't look at this. But you have to put your story together. It's like being a detective, and you have to go through all these things to figure out what's going on with your patient. You know, a lab doesn't mean anything unless you put it with something else, or finding out what they're taking the medication for, or finding out the story behind it. Because patients don't always understand what's going on when they're in the ED, when they're in the hospital, when they're at the PCPs, when they're having blood work. They don't even know what they're having it for. So it's our missing communication link.
Yeah, you said something which I do, hear from behavioral health providers in particular, that, the sense that I shouldn't be going in here. Could you talk a little bit more about that? You made that statement. I thought, I'm going to ask Brenda to talk a little bit more about that.
For me, I don't necessarily go into the behavioral health side, but it's there if I need it for something. But just going into a person's chart, and I've experienced this my whole career, you go into a person's chart and you feel guilty. I'm in here. But this is all information you use to help your client. You really need to be able to set aside, I shouldn't look at that because that's important, because your client doesn't necessarily know what that means. They don't know how to follow through with that. They need help figuring it out. And that's what we're here for, to support them, to help them to figure things out, and to maybe be that advocate for them at times, because you're noticing a trend in something that someone else didn't notice.
And you're the only one who can notice it.
At this particular organization, I'm the only one that has access to HealthInfoNet for our BHH group.
And that would be the case for so many different staff across the state who have your role, that if you don't do it, it won't get done. There's that piece too. Yeah, so that's a lot on you. And by keeping in mind that you're there to serve your client, and you're there, and it's it's part of your advocacy role, it's part of your teaching role, it's part of your role as their nurse care manager, and that kind of gets through the discomfort for you, is what I'm hearing.
Yes, yeah, it does, because if I didn't have this extra tool, I might not know that person went to the emergency department, what they went for, what I can do to help them, or what I can do to suggest for the case manager to help them.
Well, thank you so much, Brenda, for taking the time to teach us today. You've just given us some wonderful examples, actionable examples for folks who are listening in, that they can do in their own settings. And so really, thank you so much.
You're very welcome.
And now we'll hear from Shauna Oliver. Now, Shauna is the nurse care manager at Northeast Occupational Exchange. And Shauna, you go into HealthInfoNet a lot. So this may be hard for you to narrow down this to three, but I'm going to ask you, what are your top 3 favorite uses for HealthInfoNet?
You were correct. It was difficult for me to narrow it down to 3. I use HealthInfoNet to shape my day. I have a rough schedule, but things change based on HealthInfoNet. So my first most boring favorite tool is the medication reconciliation. Clients often don't understand their complete medication list. They'll forget the name. They'll know what the medication's for, but they're not quite sure how much they take or how often. So the medication reconciliation is my number 1 favorite. It it helps that it has not just their physical requirements of medications, but also their psych meds as well. So it gives that full profile look of medications. So that's my number one. My number two is education, education, education. I find the diagnostics being there and available. I find that helpful to be able to reassure clients about diagnostic testing. I have a rule for myself that I'm not the first provider to relay that information, but once they've gotten it once, if they have any questions or concerns about what they've been told, I like to be able to see that. Also can help do education as far as what the PCP has recommended, whether it be diet, activity, medication changes, things that they need to follow up the PCP as they arise. So I really find HIN is very helpful for education. My number three is actually these days it's discharge planning. I find when clients go in hospital, the discharge planning note tends to be written ahead of time, especially if they're seen by a specialty. So it kind of gives me some time and the case manager some time to kind of be looking at, okay, they're looking at discharging in a week. Are they discharging to a skilled rehab? If they are, which one are they going to discharge to? Or are they looking at discharging straight to home? Sometimes when they're looking at discharging straight to home, we feel that perhaps hospital employees don't get the full picture of what's going on with the client in their home. So myself or the case management can go in and have a meeting with everybody present, the client included, and say, hey, look, I know you're really anxious to get home, but remember, you have those steep steps that were difficult before you even went in hospital, and now it's going to definitely be a barrier. So discharge planning, where's the client? Where are they going to be next? How can we facilitate this to make it as smooth as possible? I find HIN has a plethora of information for that.
Oh, that's a lot. Those three are pretty impressive. I did want to go back and ask you about one of them that you talked about, because I think it's really important for folks who are listening in and might be new on the behavioral health home arena. And that is that you sometimes have access to information that the client doesn't yet know. And you said that this is one of your rules, not to be the first one to give them information. Could you just talk a little bit about that and how you manage that, like how you know that they don't know yet about a diagnosis or something along those lines?
I simply ask them. I'll say, they'll say I had this test done, I had a barium swallow done, or sometimes they don't even know the name of the test done, but they had to go and they had to do this and do that. And then I'll just say outright, have you heard from your doctor about the results yet? And if it's something extremely minor, for instance, if somebody's on Coumadin for the rest of their life and they've had an INR drawn, I might say, I saw your INR come across my desk today and it looked fine, but make sure you follow up at the Coumadin clinic. If it was really small, very benign, or there was a lot of anxiety involved in the result, I wouldn't tell them the result, but my clinical director has been in the same experience where it was going to be the weekend and they were completely and totally beside themselves, and they were concerned about if over the weekend they'd actually be in crisis over concern. There's some gray area there based on client need, but I always feel it's the physician's responsibility to explain test results. But that being said, they get those results explained, not always in layman's terms, more under high pressure, fast-paced, and they're not quite sure what they heard. They think they understand, but they're not 100%, which makes them no different than the rest of the population. You have a 15-minute PCP appointment, and you leave going, I think I understood, but he or she said, but I'm not 100%. So I like to reassure them about what that means and what the physician might be planning next as far as treatment or testing.
Thank you. That's helpful. And now I do have another question about, a difference that you've made in the client's life, which you've just even actually given an example of how you might do that to allay someone's anxiety. But if you would just share with us one story how HealthInfoNet made a big difference for a client because you used that system.
Very recently this happened where we have a client that has a hiatal hernia, and it's definitely affecting her life, a lot of gastric reflux and just generally feeling just miserable. And she went and she saw a surgeon, and they said, yeah, well, we can do this surgery. She had some diagnostics done, obviously, beforehand. And they said, yeah, we can do this. This is, not going to be too bad. We'll get this fixed for you, et cetera, et cetera. But first we need you to, we're going to send a consult to gastroenterology. We want you to have, I believe it was a barium swallow done. And once you have that test done, and once we get that report, then we'll proceed to book you. And about 2 months had gone by, and she was very anxious, and she had called the surgeon's office, and they said, yeah, we're just waiting for that report from gastro for you. And she was in here with her case manager, and they said, can we talk to you? And they asked me about it. And I went on to HIN, and I saw what practice her referral was sent to based on the surgeon's note. And I called that practice, and I said, hey, I have a shared client here, and she's just wondering, she hasn't heard from you folks about getting this done. And they said, we'll look into it and we'll call you back. Well, they called her and the case manager later and apologized because her referral kind of got misplaced. So they got her done. They put that diagnostic, towards the top, her being seen, get that done so that she could be scheduled for her surgery. And it just made her life so much easier because she was so anxious, and she just thought that the wait for the gastro was that long, and she didn't know the name of the physician, and she's not familiar with the healthcare system, so she didn't even know where to start calling.
Wonderful example. Do you know if the specialist had an EHR? Were they on paper, or do you know any details of how that referral got misplaced?
No, I don't know how the referral got misplaced. I do know most offices these days have almost, it's like a referral, either a nurse or an MA or somebody, and they get inundated with them. And I assume these days most of them are electronically sent, but they get a ton of them, and I don't know if it came across a fax and got misplaced, or if it was sent and something happened and it just didn't occur. It just didn't occur.
Yeah. So just by the high numbers, there's human error everywhere.
Right.
So to have this as a way to kind of double up on that and double check that.
Yes. And this is just a brief second story, but a similar thing happened with an elevated potassium, which can be dangerous. And one of our clients had routine lab work done, and I saw potassium, and I don't even remember why I was looking at her labs, and it had been done like the day before. And I called the office, and they said, oh, we haven't gotten to our lab reports. Those I know come on fax from the labs that have done them. So they kind of sit there until the day, if it's a crazy day, whoever's responsible for that has the time to sit and look at all those labs. So, that happens too. There should be a phone call from the lab itself, but once again, it's human error. Things happen. Things get busy.
And how wonderful for you as an advocate to your clients to be able to go in and make this kind of a difference.
The nurse was absolutely, could not have been more responsive. She said, oh my goodness, I'm so glad you called. Second pair of eyes is so great. it's just those fluke things where two people are looking at the same thing, doing the same job, and one gets to it before the other one.
Yeah, yeah. Or in some cases, the other one, because it's so buried, never gets to it. I mean, that happens in our fast-moving world. So, it's a great story, great story. Now, so listening in are a lot of folks who are in behavioral health homes, but not that they're new to behavioral health homes, but they're new to using HealthInfoNet. And so if you were to give a recommendation or two or three, whatever comes to mind for you, what would you suggest to these new folks, new to HealthInfoNet, in terms of using HealthInfoNet or how to use it? What comes to mind for you?
One of the first things I would say is make sure you have a champion or two, depending on the size of your agency, people that like using electronic communication, that could find some comfort right from the beginning, and have them be kind of the access place, the resource, somebody that can say, oh, that's no problem, this is what you do, don't worry. You're always going to have, whenever there's something new, you're always going to have people that take to it immediately and then other people that are going to avoid the change. And those ones that avoid the change, if it's not something they're using on a regular basis, might need to be taught more than once. So it's always good to have your champion that says, this is great, this is going to make your life easier, and this is how it's going to make your life easier, so that you got some point people. The second thing I would say is nurses specifically, if you have a huge BHH load, I recently met somebody that's got a BHH load of 500. If I was to attempt to follow all of those clients via notifications, literally that would be my day. So with HIN, you have the beauty of the tailoring the notifications. If you've got clients that are going through a lot of health crises and you want to follow them for 2, 3, 4 months and then drop them off your panel of people that you're following and rely on your coworkers to let you know if stuff comes up again, that's possible. If you have a huge caseload, again, maybe you're not going to follow labs for all your clients. Maybe you're just going to follow the ER notifications or the discharge planning. But because it's so easily tailored, don't underestimate the ability to do that.
Well, that's wonderful for all the wonderful things you're telling us, Shauna. You've been a great teacher to us today, and you're a great advocate to your clients. So thank you for taking the time. And I want to take a moment to thank all of our nurses who have presented for us, Liz, Brenda, Shauna, Doris, and Jen. A big thank you. Really, what great work you're all doing. You're empowering your staff, you're empowering your clients, and teaching us. Thank you. And for anyone on the call who would like to get in touch with me, if you have any questions or you just want to have some follow-up, please don't hesitate to reach out. Thank you for joining us today, everyone, and look forward to hearing from you. Thank you.